You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
What is depression? Depression is not just feeling sad. It is a clinical syndrome defined by persistent sad or depressed mood and/or loss of interest or pleasure, anhedonia, accompanied by psychological symptoms, difficulty concentrating, worthlessness, guilt, suicidal thoughts, and somatic symptoms, fatigue, sleep changes, appetite changes, psychomotor disturbance, lasting at least 2 weeks, most of the day, most days, and clearly different from the person's baseline functioning. The DSM-5 requires at least 5 of 9 specific symptoms, and at least 1 must be either depressed mood or anhedonia. Without one of those 2, the diagnosis cannot be made. Memory trick: the 9 symptoms of MDD, SIGE caps. S, sleep changes, insomnia or hypersomnia. I, interest loss, anhedonia. Core criterion G, guilt or worthlessness, excessive or inappropriate. E, energy loss, fatigue nearly every day. C, concentration difficulty or indecisiveness. A, appetite/weight changes, increase or decrease. P, psychomotor changes, agitation or retardation must be observable by others. S, suicidal ideation, thoughts of death, plans, attempts, plus the other core criterion, depressed mood. Core criterion, rule of 5, need greater than or equal to 5 of 9 symptoms, greater than or equal to 2 weeks, must include depressed mood or anhedonia. Screening. The PHQ-9 breakdown. The PHQ-9 is the gold standard screening tool for depression. It maps directly onto the 9 DSM-5 criteria. Each item is scored 0 to 3, not at all to nearly every day, giving a total score of 0 to 27. A score of 10 or more has 85 to 88% sensitivity and 85 to 88% specificity for major depression. Severity scoring, 0 to 4 equals minimal/none. Monitor, no treatment needed. 5 to 9 equals mild depression. Consider watchful waiting, psychotherapy, lifestyle interventions. 10 to 14 equals moderate depression. Psychotherapy and / or pharmacotherapy indicated 15 to 19 equals moderately severe. Active treatment with pharmacotherapy plus psychotherapy recommended 20 to 27 equals severe depression. Pharmacotherapy plus psychotherapy consider urgent evaluation. Board Pearl. A score of greater than or equal to 15 suggests the need for active treatment, including medication. Always assess item 9, suicidal ideation, separately, regardless of total score. A patient could score 5 overall but endorse daily suicidal thoughts on item 9, which demands immediate safety assessment. Quick screen shortcut. The PHQ-2, the first 2 items of the PHQ-9, depressed mood plus anhedonia, can be used as a rapid screen. A score of greater than or equal to 2 on the PHQ-2 warrants completing the full PHQ-9. This does not reduce sensitivity. The depression family, types you must know 1. Major depressive disorder, MDD, the classic. This is the bread and butter of depression. Discrete episodes of at least 2 weeks with greater than or equal to 5 of 9 SIGE cap symptoms, representing a clear change from baseline. Most episodes last considerably longer than 2 weeks. MDD is recurrent in the majority of cases. A single episode is possible but uncommon as the long-term pattern. The 12-month prevalence is approximately 10.4% in US adults, making it one of the most common psychiatric disorders. Up to 2/3 of patients may not achieve remission with initial antidepressant treatment, highlighting the importance of systematic follow-up and treatment adjustment. 2. Persistent depressive disorder, PDD/dysthymia. Mana The slow burn. This is the chronic, low-grade depression that never seems to fully lift. The mood disturbance must be present for at least 2 years in adults, 1 year in children/adolescents. On most days, more days than not. During this time, symptom-free intervals cannot exceed 2 months. Patients need depressed mood, plus at least 2 of the following: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. The tricky part is that patients often say, "I've always been this way." The symptoms become so woven into daily life that they may not report them unless directly asked. If a patient meets full MDD criteria for 2 years continuously, they get both diagnoses, PDD and MDD. This is called double depression. Board Pearl. PDD versus MDD is about duration, not severity. PDD can be just as impairing as MDD. It's the chronicity, greater than or equal to 2 years, that defines it. Board Pearl. PDD versus MDD is about duration, not severity. PDD can be just as impairing as MDD. It's the chronicity, greater than or equal to 2 years, that defines it. 3. Premenstrual dysphoric disorder, PMDD. The cyclical storm. HMDD is not just bad PMS. It is a DSM-5 depressive disorder characterized by marked mood lability, irritability, dysphoria, and anxiety that occur during the luteal phase, the week before menses, and improve within a few days of menses onset. Symptoms must be present in most menstrual cycles over the past year and must cause clinically significant distress or functional impairment. First-line treatment is SSRIs. And here's the unique pharmacology pearl, SSAR. It can be dosed continuously or intermittently, luteal phase only, starting 14 days before expected menses, for PMDD, because the serotonergic effect on PMDD symptoms occurs much faster than the antidepressant effect, days versus weeks. 4. Disruptive mood dysregulation. Disorder, DMDD, the angry kid. This diagnosis exists specifically for children up to age 12 with persistent irritability and frequent severe temper outbursts, verbal or behavioral, that are grossly out of proportion to the situation, occurring greater than or equal to 3 times per week, with a chronically irritable or angry mood between outbursts most of the day, nearly every day. It was created to address the overdiagnosis of pediatric bipolar disorder. Research shows these children typically develop unipolar depression or anxiety disorders as they mature, not bipolar disorder. DMDD cannot be diagnosed before age 6 or after age 18, and the onset must be before age 10. 5. Bipolar depression. The imposter. Bipolar depression looks almost identical to unipolar MDD. Same symptoms of sadness, anhedonia, fatigue, sleep changes, appetite changes, and suicidal ideation. But the treatment is completely different. And misdiagnosing bipolar depression as MDD is one of the most dangerous errors in psychiatry because antidepressant monotherapy can trigger mania, rapid cycling, or mixed states. At least 7% of patients treated for depression in primary care may have unrecognized bipolar disorder. Clinical clues that suggest bipolar depression rather than MDD include atypical features, hypersomnia, hyperphagia, leaden paralysis, psychotic features, early age of onset, abrupt onset and offset, family history of bipolar disorder, treatment-resistant depression, and history of antidepressant-induced mania or hypomania. The defining feature is a prior history of mania or hypomania. Always ask about previous periods of elevated energy, decreased need for sleep, increased goal-directed activity, and grandiosity. Board Pearl. Always screen for bipolar disorder before starting an antidepressant. Ask every depressed patient, have you ever had a period of days or weeks where you felt unusually energized, needed less sleep, or felt on top of the world? Questionnaires like the Mood Disorder Questionnaire, MDQ, can help, but sensitivity may be as low as 50% in primary care. Treatment difference. Bipolar depression is treated with mood stabilizers, lamotrigine, lithium, or atypical antipsychotics, quetiapine, lurasidone, cariprazine, not antidepressant monotherapy. DSM-5 specifiers, the flavor of the episode. Specifiers describe the character of the current depressive episode. They guide treatment selection and predict prognosis. Think of them as adjectives that modify the diagnosis. With melancholic features, the classic endogenous depression. This is the severe, biologically driven depression. The hallmark is loss of pleasure in all or almost all activities, not just reduced, gone, or lack of reactivity to usually pleasurable stimuli. Nothing cheers them up, even temporarily. Plus greater than or equal to 3 of. Distinct quality of depressed mood feels different from grief or sadness. Patients say it's a physical heaviness. Mood regularly worse in the morning. Early morning awakening, greater than or equal to 2 hours before usual. Marked psychomotor agitation or retardation. Significant anorexia or weight loss. And excessive or inappropriate guilt. Treatment implication. Melancholic depression is more responsive to pharmacotherapy and ECT than to psychotherapy alone. These patients need medication. Memory trick. Melancholic equals nothing makes me feel better, non-reactive mood. Atypical equals some things make me feel better, reactive mood. They are mutually exclusive, cannot have both in the same episode. With atypical features. The reverse pattern. Despite the name, atypical depression is actually quite common. 15 to 36% of depressed patients. The defining feature is mood reactivity. The mood brightens in response to positive events, unlike melancholic depression where nothing helps. Plus greater than or equal to 2 of significant weight gain or increased appetite, hypersomnia, greater than or equal to 10 hours per day or greater than or equal to 2 hours more than when not depressed, leaden paralysis, heavy weighted down feeling in arms or legs, lasting greater than or equal to 1 hour per day, and long-standing interpersonal rejection sensitivity, not limited to depressive episodes. This is a trait, not a state. Treatment implication. Historically, atypical depression was considered preferentially responsive to MAOIs. A 2026 large genetic study found that atypical depression is associated with poorer self-reported effectiveness of SSRIs and SNRIs, along with more side effects, especially weight gain, and has distinct genetic overlap with metabolic traits, BME, type 2 diabetes, insulin resistance, inflammation. This supports using the atypical subtype to guide treatment selection and physical health monitoring. Bored pearl. Atypical features are also common in bipolar depression. If you see hypersomnia plus hyperphagia plus leaden paralysis, always screen for bipolar disorder. With psychotic features, depression plus delusions/hallucinations. Psychotic depression involves delusions and or hallucinations during the depressive episode. It is further specified as mood congruent. The psychotic content matches depressive themes. Guilt. I've ruined everyone's life. Worthlessness. I'm rotting inside. Nihilism. The world is ending. Disease. I have cancer and no one will tell me. Deserved punishment. I deserve to suffer. Mood incongruent. The psychotic content does not match depressive themes. For example, persecutory delusions, thought insertion. Mood incongruent features carry a worse prognosis. Treatment implication. Psychotic depression responds poorly to antidepressant monotherapy. The standard treatment is an antidepressant plus an antipsychotic, or ECT, which is particularly effective for psychotic depression, especially with mood-congruent features. With anxious distress, the most common specifier. This is the most prevalent specifier in community samples. It describes depression accompanied by prominent anxiety symptoms, feeling keyed up or tense, feeling unusually restless, difficulty concentrating because of worry, fear that something awful may happen, and feeling that the patient might lose control. Severity is rated as mild, 2 symptoms, moderate, 3 symptoms, or severe, 4 to 5 symptoms. Treatment implication. Anxious depression is less responsive to antidepressants than non-anxious depression, SSRIs and SNRIs are preferred. They treat both depression and anxiety. Bupropion and levetiracetam are generally not recommended for anxious depression because they can worsen anxiety. With mixed features, the bipolar bridge. This specifier describes a depressive episode with greater than or equal to 3 manic/hypomanic symptoms. Elevated mood, grandiosity, pressured speech, racing thoughts, increased energy, increased goal-directed activity, decreased need for sleep, risky behavior. This is clinically important because mixed features may indicate an underlying bipolar spectrum illness and predict future bipolar conversion. Antidepressant monotherapy should be used cautiously. Mood stabilizers may be more appropriate. With peripartum onset, not just baby blues. This specifier applies when mood symptoms begin during pregnancy or within 4 weeks of delivery. Note, about 50% of postpartum episodes actually begin during pregnancy. Hence the term peripartum. Peripartum depression affects approximately 10 to 15% of women and is distinct from the baby blues, which affects up to 80% of women and resolves within 2 weeks postpartum. Peripartum depression involves full MDD criteria and can include intrusive thoughts about harming the infant, severe anxiety, and impaired bonding. Screening is recommended during pregnancy and postpartum using the Edinburgh Postnatal Depression Scale, EPDS, or PHQ-9. Treatment includes SSRIs. Sertraline is often preferred due to low breast milk transfer, psychotherapy, IPT, and CBT, and for severe cases, brexanolone, Zulresso, IV infusion, the first FDA-approved treatment specifically for postpartum depression, or zuranolone, Zurzuvae, the first oral medication specifically approved for postpartum depression. With seasonal pattern, winter depression. This specifier applies when depressive episodes have a regular temporal relationship with a particular time of year, most commonly fall/winter onset with spring/summer remission. The seasonal episodes must substantially outnumber any non-seasonal episodes over the patient's lifetime. The mechanism involves reduced light exposure affecting circadian rhythms and serotonin/melatonin balance. Treatment. First line is light therapy, 10,000 lux white light for 30 minutes daily, typically in the morning. SSR is, especially bupropion XL, which has an FDA indication for prevention of seasonal depression, are also effective. Light therapy is also effective as adjunctive therapy for non-seasonal depression. With catatonia. The frozen state. Catatonic features during a depressive episode include stupor, catalepsy, waxy flexibility, mutism, negativism, posturing, mannerisms, stereotypies, agitation, grimacing, echolalia, and echopraxia. This is a medical emergency requiring urgent treatment. First line is benzodiazepines, lorazepam challenge, 1 to 2 milligrams IV. Dramatic improvement within minutes supports the diagnosis. ECT is highly effective for catatonic depression, especially when benzodiazepines fail. Board Pearl. Do not give antipsychotics to a catatonic patient. They can worsen catatonia and precipitate NMS. Benzodiazepines first, ECT if refractory. Treatment, the step-by-step approach. Step 1. Match treatment, intensity to severity. Mild depression, PHQ 9-5-9. Psychotherapy alone is appropriate as first line. Lifestyle interventions, supervised exercise 30 to 40 minutes, 3 to 4 times per week for greater than or equal to 9 weeks, are first-line monotherapy for mild depression. Watchful waiting with active monitoring is also reasonable. Moderate depression, PHQ 9-10 to 14, pharmacotherapy or psychotherapy or both. Medication is more effective than psychotherapy alone during acute treatment for moderate depression. Moderately severe to severe depression, PHQ 9-15 to 27. Combined pharmacotherapy plus psychotherapy is more effective than either alone and decreases recurrence. This is the standard of care for severe depression. Step 2. Choose your first-line medication. All first-line antidepressants have similar overall efficacy. The choice is guided by side effect profile, patient symptoms, comorbidities, and patient preference. No single antidepressant is clearly superior to another for initial treatment. SSR is sertraline, escitalopram, fluoxetine, paroxetine, citalopram, the most commonly prescribed first-line agents. Common side effects: nausea, headache, insomnia, sexual dysfunction, diarrhea. Escitalopram, sertraline, and paroxetine have evidence of superior efficacy in meta-analyses. Paroxetine is more anticholinergic, avoid in elderly. SNR is venlafaxine XR, duloxetine, desvenlafaxine, levormilnacipran. First line, especially useful when comorbid pain, duloxetine for diabetic neuropathy, fibromyalgia, chronic musculoskeletal pain, or when SSRIs have failed. Venlafaxine may increase blood pressure. Monitor. Duloxetine has the broadest pain indications. Bupropion, Wellbutrin, first-line unique mechanism. Norepinephrine dopamine reuptake inhibitor. The go-to choice when you want to avoid sexual dysfunction, weight gain, or sedation. Also FDA approved for smoking cessation and seasonal affective disorder prevention. Do not use in patients with seizure disorders, eating disorders, bulimia, anorexia, or significant anxiety can worsen it. Mirtazapine, Remeron, first line, works by blocking alpha-2 adrenergic receptors and 5-HT2/5-HT3 receptors. The go-to choice when you want sedation, insomnia, appetite stimulation, underweight patients, or anti-nausea effects. Major side effects: weight gain and sedation, both dose-dependent. Paradoxically, sedation is worse at lower doses because antihistamine effects predominate. At higher doses, noradrenergic activation counteracts sedation. Memory trick for matching medication to symptoms. Patient can't sleep plus losing weight leads to mirtazapine. Sedating plus appetite stimulating. Patient is fatigued plus gaining weight plus has sexual dysfunction leads to bupropion, activating weight neutral, no sexual side effects. Patient has comorbid anxiety leads to SSRI or SNRI, not bupropion. Patient has comorbid chronic pain leads to duloxetine or venlafaxine. SNR is. Patient has comorbid smoking leads to bupropion, dual indication. Step 3. Choose your psychotherapy. All evidence-based psychotherapies for depression have similar efficacy. None is clearly superior to another. The choice depends on patient preference, symptom profile, and therapist availability. The optimal amount is 12 to 16 sessions, and twice-weekly sessions produce better outcomes than once weekly. CBT identifies and modifies negative thought patterns. Best studied, most widely available. Also effective for relapse prevention. Interpersonal therapy, IPT, addresses interpersonal issues, grief, role transitions, interpersonal disputes. Especially useful when relationship problems are prominent. Behavioral activation, BA, schedules positive activities and increases rewarding interactions. Particularly useful for patients with low motivation and withdrawal. May produce greater symptom reduction in group settings for less severe depression. Mindfulness-based cognitive therapy, MBCT, combines mindfulness meditation with CBT. Particularly effective for relapse prevention in patients with greater than or equal to 3 prior episodes. Acceptance and commitment. Therapy, ACT, focuses on psychological flexibility and values-based action rather than symptom reduction. Short-term psychodynamic psychotherapy, STPP, explores unconscious patterns and past experiences. Recent RCTs show non-inferiority to CBT. Step 4, timeline and follow-up. Initial response: expect 2 to 4 weeks for initial improvement, 6 to 8 weeks for full therapeutic effect. Follow up at 1 to 2 weeks after starting medication, especially for safety monitoring and suicidality in patients less than 25 years. FDA black box warning. If no improvement by 4 to 6 weeks at adequate dose, reassess diagnosis, confirm adherence, consider dose optimization. If partial response by 6 to 8 weeks, consider augmentation, adding a second agent, or switching. If no response by 8 weeks, switch to a different antidepressant class or augment. Step 5. When first line fails, augmentation, and switching. Treatment-resistant depression, TRD, is defined as failure to respond to at least 2 adequate antidepressant trials. This affects 10 to 30% of patients with MDD augmentation strategies, adding to the current antidepressant. Atypical antipsychotics, the strongest evidence base for augmentation. Aripiprazole, 2 to 15 milligrams per day. Brexpiprazole, 1 to 3 milligrams per day. Cariprazine, quetiapine, 150 to 300 milligrams per day, and olanzapine-fluoxetine combination, Symbyax, all have evidence. Aripiprazole has the most robust data. Monitor for metabolic syndrome, EPS, and akathisia. Lithium, classic augmentation agent, though evidence is mixed. The STAR*D trial showed 15.9% additional remission with lithium augmentation, may decrease suicide risk. Requires level monitoring, renal and thyroid function checks. Bupropion. Adding bupropion to an SSRI/SNRI is common practice. A 2023 study suggests bupropion augmentation may be as effective as aripiprazole augmentation in older adults. Thyroid hormone, T3/liothyronine, effective in the STAR*D trial irrespective of thyroid status. Modest evidence base, mostly with TCAS. Buspirone, mixed evidence. STAR*D showed some benefit when combined with an SSRI. Mirtazapine, reasonable augmentation option for patients with insomnia, anxiety or weight loss, but may increase fall risk in elderly. Esketamine, Spravato, FDA approved for TRD, failed greater than or equal to 2 adequate trials, as augmentation to an oral antidepressant, and for MDD with acute suicidal ideation/behavior. Administered intranasally under REIMS program supervision. A 2023 NEJM trial showed esketamine augmentation improved remission rates versus quetiapine augmentation, 27.1% versus 17.6% at 8 weeks. Ketamine IV improves depressive symptoms within 24 hours. Effects persist up to 7 days with augmentation, particularly useful for acute suicidal ideation. ECT, the most effective treatment for severe treatment-resistant depression, psychotic depression, and catatonic depression. Response rates of 50 to 70% in TRD, TMS, transcranial magnetic stimulation, FDA approved for TRD, non-invasive, well-tolerated. Step 6. Maintenance. How long to treat? First episode, continue antidepressant for at least 6 to 9 months after achieving remission. Second episode, or high-risk features, continue for at least 2 years. 3 or more episodes, chronic depression or severe episodes. Consider indefinite/lifelong maintenance therapy. Discontinuation. Never stop antidepressants abruptly. Taper gradually over weeks to months to avoid discontinuation syndrome. Dizziness, nausea, irritability, brain zaps, flu-like symptoms. Paroxetine and venlafaxine have the highest risk of discontinuation syndrome. Fluoxetine has the lowest risk. Long half-life provides a built-in taper. Critical safety points, FD a black box. Warning: all antidepressants carry a warning for increased risk of suicidal thinking and behavior in children, adolescents and young adults, ages 18 to 24, during the first few months of treatment. Monitor closely weekly for the first 4 weeks, then bi-weekly for the next 4 weeks, then at 12 weeks. Serotonin syndrome can occur with any serotonergic drug combination. Watch for clonus, hyperreflexia, agitation, hypothermia, diaphoresis. See the full serotonin syndrome guide for details. Hyponatremia, SIADH. SSRIs and SNRIs can cause hyponatremia, especially in elderly patients and those on diuretics. Monitor sodium in at-risk patients. QT prolongation. Citalopram has a dose-dependent QT prolongation risk. Maximum dose is 40 milligrams per day, 20 milligrams per day in patients greater than 60 years, hepatic impairment, or CYP2, C19 poor metabolizers. Bleeding risk. SSR is inhibit platelet serotonin uptake, increasing bleeding risk. Use caution with concurrent NSAIDs, anticoagulants, or antiplatelet agents. The 10 things you must know for boards, SIGE CAPS. 9 symptoms. Need greater than or equal to 5 for greater than or equal to 2 weeks. Must include depressed mood or anhedonia. PHQ 9 greater than or equal to 10 equals screen positive for MDD. 85% sensitivity, 85% specificity. Greater than or equal to 15 equals active treatment needed. PDD equals greater than or equal to 2 years of depressed mood, 1 year in kids. Can coexist with MDD, double depression. Always screen for bipolar before starting an antidepressant. Antidepressant monotherapy in bipolar equals disaster. Melancholic equals non-reactive mood. Nothing helps. Atypical equals reactive mood. Some things help. They are mutually exclusive. Psychotic depression equals antidepressant plus antipsychotic, or ECT, not antidepressant monotherapy. First-line meds equals SSRIs, SNRIs, bupropion, mirtazapine. Match side effect profile to patient symptoms. Treatment-resistant depression equals failed greater than or equal to 2 adequate trials. Augment with atypical antipsychotic, strongest evidence, lithium, T3, bupropion, or esketamine. Peripartum onset equals during pregnancy, OR within 4 weeks postpartum. 50% start during pregnancy. Discontinuation syndrome, taper slowly. Paroxetine and venlafaxine equals highest risk. Fluoxetine equals lowest risk.
Thanks for watching. Like and subscribe for more content.